Hi, everyone. I'm Vidya. I'm a volunteer with Fertility Matters Canada. All week long, Fertility Matters has been bringing you Facebook Lives with new and informative information to help you in your fertility journey. So today is no different. We've got Dr. Dan Nayot from Trio Fertility here with us. As you know, Fertility Matters is a not-for-profit organization and relies heavily on donations from the public and also from professional organizations. So we're very thankful to all of you who support us and also for today's sponsor, Ferring Canada. So as I said, we're here with Dr. Dan Nayot. Dr. Nayot's here to talk to us about advances in assisted reproductive technologies, and we're really looking forward to it. So hi, Dan.
Hi, how are you? Thanks for having me.
No problem. I would like to mention also that Dr. Nayot is a board member with Fertility Matters Canada and does some great work with the organization as well. So hopefully he'll give us a plug at the end as well.
At the beginning and the end. Okay, thanks for having me. I think usually our videos are done way earlier, so this is like our first 8 p.m. one, so it's either going to be not attended or very well attended. We're about to find out. But I have nowhere to go, so I'm happy to stick around and answer as many questions as possible. The lecture I'm going to do today is called Advances in Assisted Reproductive Technology. So first of all, thank you for Ferring for always supporting us, and especially tonight, so thank you very much. And I'll get started. So 1 second here. So a few things. One, I can't see you, but you can see me. So this is going to be me just shouting at a computer for a little while. But please interrupt me and ask as many questions. We do get your questions, and I hope you make this interactive. I'm going to make a few ground rules here. One, this is a very superficial overview. What I'm really hoping to do is to show you all the really cool advancements of infertility. I feel like a lot of people, let's say those who are going through it, feel like we do the same thing every clinic, but the truth is it's such a fast growing field. So I'm just going to do a superficial overview. I don't have time to go into anything too deeply unless you're interested, so I won't go so much into the science, just sort of highlighting like why this is new and why people may consider it. I'm for sure not, just because I bring something up doesn't mean I'm endorsing it. Like I'm not talking about the scientific validation and the pros and the cons. I'm just sort of telling you it's out there. But you know, the reason I went into infertility personally is I thought it was a rapidly evolving field. It's relatively new. If you think about it, the first IVF baby is like 42 years old, which in the world of medicine is like nothing. So, you know, some of the physicians I work with were around a few decades before me, and you know, the stories they tell you, it looks like it almost seems like they're lying, like the way they did fertility care 20 or 30 years ago, and that's probably what they're going to think about us now. So I picked this lecture because I really like seeing like what people are working on, and I personally am involved with a few of these things, so I'm totally biased. Here's my shameless plug in the middle is Future Fertility is an AI technology company that I help co-found, and we can talk about that as well. But again, this is not an exhaustive list. It's mostly related to IVF because I had to focus on something. And I'm assuming everybody on the other side of this camera is a patient, not a PhD in embryology. So I'm going to try to keep it as basic as possible. But if you want to dig deeper, just send us a message, okay? All right, fasten your seatbelts. Here we go. Okay, so before we talk about like what's new in IVF, I got to make sure you know what in the world is IVF. So IVF is in vitro fertilization. In a very simplified manner, it involves hormones to grow follicles. Follicles are little black circles we can see in ultrasound in the ovary. Then it involves a small procedure called the egg extraction, where we can go in and drain these follicles and find these little eggs. Then we put sperm and egg together to create embryos. We support the embryo growth, and then we usually put the embryo back, called the embryo transfer, and hopefully it's successful. In this picture, you're seeing twins. It's not really what we aim for, but I thought it was a cute picture. So that's IVF in general. Everybody, give or take, does it the same way, but the details and the nuances are very important. So Vidya, feel free to interrupt me as I go along, because I think you're fielding the questions.
I am, yeah. So far, people are just really excited about the science, but keep going.
Okay, so again, I'm going to keep it superficial just so I don't lose anybody. But if anybody wants to dig deeper or you even have so just let us know, okay? Okay, so first, these are trends. This is like my personal opinions of trends I've seen of all the conferences and thousands of physicians I've spoken to. So one thing that's a big trend in our field is, maybe 20, 30 years ago, our goal was like, let's just get them pregnant because we may not be able to get them pregnant. Now it's less just getting pregnant, but a healthy single pregnancy. We're almost being judged on that. And we can see every year that our singleton birth, which is one baby at a time, is going higher and higher, which is great. So we're focusing on a single healthy baby. That's the main outcome. We're trying to minimize a few parameters like, hopefully there's technology to get us pregnant faster, not 5 years, but hopefully 3 months. Hopefully we have, again, a singleton and not twins or triplets. And another big trend is obviously anything we can do to prevent what we call ovarian hyperstimulation syndrome, or OHSS. In this, I don't know if you can see my arrow, but in this diagram, you can see an ultrasound of someone who's got a whole lot of follicles. And although that's exciting because it may lead to a lot of eggs and hopefully success, it comes with a lot of risk of being unwell and getting really, really sick. So nobody wants to get OHSS. So a lot of the trends we see now are strategies to minimize that. So in a nutshell, kind of the general trend here now is what we call agonist triggering. It's a way to minimize OHSS. Definitely a trend is, back in the day, we used to grow embryos to day 1 or day 2 and then put them back. Then we moved on to day 3, and now we are doing day 5 or day 6, which are called blastocysts. It's quite popular these days to test these embryos to make sure they're chromosomally normal. It's very common to freeze those embryos. One of those reasons we freeze them is so we can actually get the results of the biopsy back. And again, since we're aiming for one baby at a time, we're trying to do one embryo at a time. So that's of course, not everybody does that, but that's sort of the general trend. Okay. In terms of protocol, I think that's the art of ART, as we like to call it. Every doctor you go to, or I'd say every clinic you go to, and every doctor within that clinic you go to has their own sort of special approach to it, which is fine, but the rationale should be similar. In a very simplified version, for people who have a high reserve, so lots of follicles, these are usually younger patients or patients with polycystic ovaries or PCOS, where we know if we give them hormones, they may look like that ultrasound I'm showing you. Although their yield of eggs is great and that helps us with success rates, they can also get really sick. One of the big, I mean, it's obvious now, but maybe 5, 10, 15 years ago, we figured it out. One of the best ways to prevent OHSS is to do IVF in 2 sort of segments, create embryos and freeze them. You let the hormones go back to normal, and in a subsequent cycle, very calmly put that embryo in. And the reason is because if you're pregnant, you release this hormone called beta-HCG. That's what we pee on the stick for, the pregnancy test. And that hormone beta-HCG just makes all the other hormones just explode. So patients who stimulate really well and we put a fresh transfer, so we put an embryo in and she gets pregnant, which is the whole point of the embryo transfer. Yes, we're excited because she's pregnant, but she can get really sick. So because of that, we almost know ahead of time that for these high responders or high ovarian reserve patients, we're going to do this as a 2-step approach. Make embryos, freeze them, let everybody's body come back to normal, and then calmly do it down. Okay, the reverse or the other side of this coin is the low responders. These are patients who have less follicles or less reserve, which is also measured by hormones called AMH. And again, just as a side note, ovarian reserve is a measure of a quantity, not a quality. Although it's true as we age, both quality and quantity decrease, ovarian reserve generally is just a measure of a quantity. So of course, if you have a lower quantity if your reserve is lower, we expect less eggs. And unfortunately, if we have less eggs, we expect our outcomes not to be as great. I think that's just simple math. So when we're talking about low responders, generally we're trying to think of like, what can we do to maximize the number of eggs that we're going to get? This is something that's
Dan,
debated.
We've got a question about what's the perfect target number of eggs that you're aiming for?
Oh, it's a good question. That's like a 30-minute answer. Not all fertility doctors agree, which is, I can only give you my opinion, which I guess is why you're online. So as a general rule, the more eggs you have, the better the chance of success cumulatively, which means, okay, let me, yeah. So the more eggs you have, the more embryos you're going to make, and the more embryos you're going to make, the more likely the end result after you've used up all those embryos is going to work. Okay, that's one school of thought. So one school of thought is get as many eggs as you can, because cumulatively you'll have more success. Of course, we don't want to just go full speed ahead, because people can get quite sick. But there are. Sorry, I told you it was a long answer. There are some people whose school of thought is that the more eggs you have, the lower the quality of the eggs. I think they base that on what we call the fresh transfer rate. So if you, okay, I'm going to take a timeout because I think this is a long-winded answer. The less eggs you have, okay, third time's a charm, okay. In Japan, we'll start there. In Japan, they do what we call natural IVF. So they almost give no hormones, which means we're probably going to grow 1 or 2 follicles. This is on purpose. That's the plan. And they get 1 or 2 eggs, hoping that that's the best egg in the cohorts. We know that the chance of success for that IVF cycle is way, way lower. And the way they overcome that is by just doing more IVF cycles. Okay. If you measure success by fresh transfer, which means I took hormones, I took out my eggs, and then I put an embryo in, then you don't want too many eggs, because those super high hormones aren't great for a fresh transfer. So, but if you take a cumulative approach, which is usually how I see it, which means that someone who is sitting in front of me says, I'm going to do IVF, and when you're done all those embryo transfers, which may be 2, 3, 4, 5, 6 transfers, will I have a baby or not? As a general rule, the more eggs, the better. I'm going to add a little more caveat to that. I personally believe in sort of diminishing returns. So I think if you have 5 eggs, you'll always do better than 2 eggs statistically. 10 eggs, you'll do better than 5 eggs. 15 eggs, slightly better than 10 eggs. But probably after that, egg number 18, egg number 32 is probably of quite low quality, but I don't think it affects the first 30 eggs. So it doesn't add very much value. A super long answer to, if I had a choice to control the outcomes, I would sort of go for like the 8 to 16 eggs. But of course, women are not robots and they don't come with like a manual to do that, but that's sort of what we're aiming for. I promise the future answers will be shorter than that.
That's awesome. Thank you.
Okay, so for low responders, people who have low number of eggs, we're trying to get out more eggs. So many strategies here. One really popular one that probably has the most evidence, although I said I wouldn't talk about evidence, is testosterone priming, some form of testosterone. I think the one that most people know about is DHEA, which is like an oral testosterone. You take it 3 times a day. Another one is called Androgel. It's a cream, so it's a transdermal testosterone, but it's something we take 2 to 12 weeks before an IVF cycle to try to give us more follicles and more sensitive follicles. I'll skip that second line and go to the third line, co-treatment. There are many physicians who try, what else can we try other than fertility drugs? So we call it co-treatment. So some people try Cyzen. Cyzen is like a growth hormone. And some people try letrozole. Letrozole is a pill that you take because some studies have suggested it may give us an extra egg in each cycle. And for these low responders, any extra egg will increase our chance. Mini IVF has been a popular term in the last few years. Essentially, it's nothing unique. It's just saying less medications. The rationale here is somebody with a low response has a ceiling effect. So no matter, just because you go higher on your drugs doesn't mean we'll produce more eggs. So there's probably no need to go on such a high drug dose if you're already maximized. So mini IVF is sort of a term to say, like, just to go lower on your medications. Okay. Is there any questions on that, or should I proceed?
Can high doses of medications affect the egg quality?
Yeah. So the question was, do high doses of medication affect egg quality? I think it depends who you ask, and it's debated. In my opinion, no. I think the people who suggest yes use the following evidence. So imagine you have 10 eggs, and out of those 10 eggs, you made, okay, let's say 10 embryos, and you tested those embryos, and 2 of those embryos were normal genetically. So you had 10 eggs turn into 2 normal embryos. So you have a 20% euploid rate, okay? Now let's say you went way higher on your drugs and you got 20 eggs. And let's say those 20 eggs made it to 3 normal embryos, okay? So you can say that, look, 3 out of 20 is a lower rate than 2 out of 10. So, or sorry, 2, yeah. Yeah, so is my math right there? So yeah, 7.5% is lower than 10%. So 20 eggs to 3 embryos is a lower percentage than 10 eggs to 2 embryos. That's correct math. But as the patient, I think you would rather have 3 normal embryos than 2 normal embryos. So when you're looking at it cumulatively, I believe the more eggs you have, the better.
Okay, great.
So I think it's different ways of approaching it. But as a general, I personally don't believe that, but there are many physicians who do, but it's something that we debate all the time.
Okay. Can someone take letrozole for ovarian stimulation before doing an HSG test to check the tubes?
Oh, that's a very specific question. So, so can you ask that again? Can somebody take letrozole during ovarian stimulation?
Can someone take letrozole for ovarian stimulation before doing an HSG test to check the tubes?
So if I'm understanding the question right, are they asking, I don't know if they're asking, could you try treatment before checking your tubes? I mean, I think if I understood that question right, my answer is that all of fertility is personalized. Generally speaking, we like to do a full workup first. Like if your tubes are blocked, then maybe that's not the right treatment for you. But that's between you and your doctor, like when you check what and things like that.
Okay. Does a shorter stimulation cycle lead to poor quality eggs?
Oh wow, we've got some. So there's
These
a
are great
shorter.
questions.
Yeah. I think people are going to get annoyed with my long answers, but I don't know how to answer them shortly. So first of all, for the physician point of view, whether a cycle is short or long, we generally look at the follicle size and the hormones before we decide to trigger. So it's not like we're planning a short or a long cycle. We sort of respond to what we see. So we believe short or long cycles are sort of a downstream effect. So for example, patients with lower reserve or older patients, we generally see shorter cycles. So I think it's maybe an indirect measure, but I can tell you the evidence to say that short cycles turn into worse eggs is weak at best.
Okay.
All right.
There are more questions, but I'll let you continue and actually talk about
haven't even gone, this is good. This is just general. I haven't gone even to the technologies that are out there.
Yeah.
I'm going to skip the transfer protocols because I think maybe we'll just go to what's new out there. So again,
we have a very sophisticated audience tonight.
Yeah, I know. I should have put more slides, but it's okay. I enjoyed it. So in terms of medication, let's talk about the basics. So if our audience here has been through IVF, they might know there's essentially 3 types of medications. There's medications to stimulate the follicles. So that's some form of FSH and yes or no to LH. Those are many types of products out there. There are medications to prevent your ovulation, and then there's the trigger medication to start the maturation process. So you need some form of that to do traditional IVF. There are some new medications that are out there. One of them is letrozole. It's not so new, but it's relatively new because maybe patients these days don't know, but Clomid used to be the letrozole. It was been around for like 50 years. It's kind of off the shelf now. Not that it doesn't work, it's just probably just not cost effective for pharmaceuticals to create it. People want to take 5 pills at a time. It's relatively cheap to make. So letrozole works very, very similarly. We use it as if it was Clomid. So letrozole is kind of known as the new Clomid, although you can still get Clomid if you go to a compounding pharmacy. One of the newest FSH hormones out there is called Recovil, which is actually by Frank. So there you go. There's a few things that are novel about Recovil. One of them is, so it's recombinant, which means it's synthetic. It's made in a lab. There are other recombinant FSH on the market. This one is made out of human cell line, which maybe the audience says isn't at all, but actually the rest of the recombinant is made out of like Chinese hamster cells, we call it. I'm not going to talk about the science and the pros and cons, just to highlight that there's a new recombinant FSH out there. And one of the ways Recovil was sort of introduced to the market is that, they say that they came out with an algorithm to try to help get a specific number of eggs. So kind of like the first question, if we can control the number of eggs we get, I would, but we can't always. So Recovil's approach is, hey, if you use our algorithm, you're more likely to get to that sweet spot we think is the best. There is a medication called Elonva. I think that's the right name. It is a long-acting FSH, so anyone who's taking fertility drugs, kind of like the picture in the upper right there, there's a whole lot of injections. So long-acting FSH is sort of like a depot that lasts for a week. So instead of taking a daily injection, you could take one, and then a week later, move on to day 8 and day 9. It's not yet available in North America, as far as I know. Anyone who's ever done an embryo transfer has been a victim to progesterone and oil. These injections go in our muscles, so in our buttocks. A lot of times patients complain about, I've never had it done. I don't think it's fun. So there is a company out there that's trying to bring this subcutaneous, which is a much easier way to take it into North America, but not yet available. But I'm just sort of highlighting what's out there. There's always innovations. Another exciting pharmaceutical intervention is called atosiban. Atosiban is an oxytocin antagonist. So oxytocin, if anyone's ever gone into labor and delivery, it's like the medication we use to contract the uterus to help with labor. We think when embryos are being put into the uterus, we want the opposite. We want a really quiet uterus so it doesn't cramp out the embryo. So the thought process there is, if I have a oxytocin antagonist, maybe I can calm the uterus and maybe the embryo transfer will be more successful. So this company is trying to use this drug for patients who have failed multiple embryo transfers. And again, I'm not going to comment on the science or the validation. I'm just sort of highlighting interesting things that are on the field. Okay. So nothing I said is like a endorsement of anything. Should I move on to the next slide, or is there something about this slide? Questions here?
There's one more question. Is gonalf still an effective stim, or are we looking more at the new things on the market?
So the reason I didn't mention gonalf is because it's just not new. I'm just trying to highlight newer stuff that you may not have heard of. But yeah, it's totally an effective recombinant FSH.
Right. It just depends on what works for which people.
I didn't mention it because it's not new. So I'm just trying to highlight stuff you may not have heard of.
Perfect.
Okay.
We have a couple more before we get into the actual technologies, if that's okay.
Sure.
How do you prevent hyperstimulation in patients with PCOS?
Right. So how do you prevent, so the question is, how do you prevent hyperstimulation with patient PCOS? So patients with PCOS have follicles like this ultrasound, lots of follicles. And when you give them medications, those follicles grow and we get lots of eggs and the hormones are high and they can get very, very bad OHSS. Generally, there's 4 ways to do this. One, you have to be detailed as a physician and dosed properly. So you don't want to give someone PCOS a mega dose. That just doesn't make sense. You're going to get them really sick. So that part's obvious, but you have to be vigilant. The second, what we learned is, remember I said the hormone HCG can make things so much worse. So normally when we do a trigger, we give HCG. And one thing we learned probably in the last 5 years, so it's relatively new, is that instead of HCG, if you give something like a GnRH agonist trigger only, the OHSS rates are substantially lower. So if you know you are at risk for OHSS, you want to go in a normal or low dose. You want to give an agonist trigger. You don't want to put that embryo in because, again, if you get pregnant and you have that beta HCG, you're going to get super sick. So you want to freeze all those embryos. Those are the three most important pillars of preventing OHSS. The fourth one is there are medications you can give someone after the retrieval to sort of reverse the stimulation, to sort of shut everything down. So those are sort of the four aspects.
Great. Does starting IVF on cycle day 2 make a difference versus day 4 or 5?
The question was, does starting IVF, which means starting the stimulation medications, make a difference if you go day 2 versus day 4, day 5? Is a general rule. The reason we want to start on, oh God, you're going to hate my long-winded answers, but traditionally when IVF started, we would do fresh transfer. So we start at the beginning, we grow follicles, we take out eggs, we make embryos, and we put it in, okay? We have actually, more and more evidence suggests that you can start stimulation any time of the cycle, day 10, day 14, day 20, whatever you want, as long as you don't put those embryos back, because then you're not synchronized. So if you're doing a freeze all cycle, you can actually start whenever the heck you want, because you're not putting those embryos out, although it's not very popular and it's sort of, it feels weird to bleed in the middle of your stimulation. It's not very, but the science part of it, you can start whenever you want. We see this specifically in like cancer patients who don't have so much time and it's get their eggs now or you never have a chance. We don't wait till their next day 2, we just go. So if you're aiming for a fresh, so that's the first comment. The second comment, when we start stimulation, we almost want all the follicles to be lined up. We think about like the horses lined up, we want them all to race together. So that's why we sort of start on day 2, day 3, when the follicles are all lined up. If we start doing it on day 5, day 6, you start having already sort of a lead follicle. But again, a lot of times, this is just in general, I mean, if you ultrasound and do blood work on day 5 and it looks like everything's synchronized, then yes, on paper you're on day 5, but on ultrasound and blood work, it looks like a synchronized day 2. You can go ahead and start then.
Awesome, thanks.
Keep it going?
Yeah, well, do you want to talk about technology now?
Now we'll talk about technology. So the lecture is about to start. This is the more fun part. I am like, my real passion is like medical startups in the fertility space. So I know all these companies. I love learning about it. I like seeing people's like unique approaches. A lot of them have become my friends. So I'm just highlighting, again, not endorsing anything, just sort of highlighting what's out there. So we'll start with outside the lab and then we'll end with inside the lab. So outside the lab, there's a lot of these prediction algorithms. I think that's really helpful. There's a lot of free online calculators. What is the chance of like succeeding? And you punch in a few variables like your age, your reserve, your partner's sperm, how long you're trying, and it'll give you like a ballpark. I think that's really, really helpful. So you know what I see patients all the time that think they have an 80% chance when I'm thinking they have a 7% chance. And that's where you have a lot of problems where you've got to manage expectation because that creates more resilient patients. And with persistence, you're going to succeed. So those are free online calculators. There's a company called Unify that does it a little bit more detailed than that. It has these really nice reports. We use it at Trio Fertility, and I find it as a really good counseling tool. Of course, it's a prediction. It's not 100% accurate. We're just looking for ballparks here. There's a lot of cool technologies out there for people at home. I guess that's very COVID relevant. We did a webinar about that, I think, 2 weeks ago. I did the webinar on it. Go check it out for more details, but there's a lot of cool stuff you may not have known that you could do at home. One of them is like testing your urine FSH or even checking your urine progesterone. Everybody knows about LH, which is ovulation, and beta HCG, which is pregnancy, but there are actually ways to check your urine FSH and progesterone. You can actually do semen analysis at home. Of course, this is not lab level results, but at least some sort of intel for you. And there's a company called Stork, which helps you do sort of inseminations at home. I don't know if you guys can see my arrow, but essentially the semen is collected and put into a little, almost like a cervical cap. And this contraption here goes through the vagina and puts the cervical cap near the cervix. So just putting as much sperm as you can around the cervix. I think the target audience here is either like same-sex couples who want to use someone else's sperm, or single women who want to use someone else's sperm, or couples who are having difficulty having intercourse for many, many reasons. But that you can buy over the counter. I just thought it was a clever, yeah. Vidya, you look like you have a question.
I have my own question, which is like,
You
what's
gotta
the
type it in.
success rate? What's the success rate of this at-home kit versus doing an IUI?
Right. So again, it's not targeted. I mean, I'm not going to the validation of all of these, but I think the idea here, this is not instead of IUI. This is sort of for patients who can't have proper vaginal intercourse. Yeah.
Great.
But no, IUI is different in two reasons. IUI, what we do is we actually process the sperm and wash it. And we go through the vagina and through the cervix and put it near the top of the uterus at the right time. So it's a little bit different. But this is not the target.
Great.
But all of these companies, the best part of them is all their names. I think it's clever.
Yeah. I'm in marketing. I get it.
Okay, I'll move on. So another outside the lab, I consider someone's uterus outside the lab. So this is the endometrium. I divided it into non-invasive. So people get ultrasounds all the time. So that's not new technology, although there's different ways of looking at it. At Trio, we published 2 studies that I think are really exciting, but I don't have time to talk about that. There is a company, this is a Canadian story, called Matris. And what Matris does is says, like, give me your ultrasound and let us run our own algorithm and sort of give you a score of how likely they think it's going to implant or not. Again, I'm not talking about validation and endorsement, but just to know what kind of products are out there. In terms of invasive testing, that requires an endometrial biopsy. So we got to go in with a little pipelle, get some tissue inside the uterus. And then there's so many things you can do to analyze that tissue. One I think a lot of people have heard of already is called ERA, which is endometrial receptivity assay. There are many ERA-like tests out there, but the idea here is give us your tissue, we're going to analyze the proteins, and we're going to tell you if this is a receptive. So we believe in this concept called the window of implantation, because if you're putting the right embryo at the wrong time, it may not hit. And maybe that will guide you and your doctor how to change your protocol for your actual transfer. A relatively new test that came out of iGenomics probably in the last 6 to 12 months takes this endometrial tissue, so the biopsy is the same, but analyze it for bacteria that might be causing what we call chronic, like an underlying infection, or a microbiome analysis. That in itself is a relatively new realm in the world of fertility, and I think it's exciting. We used to think that the uterus was sterile, like you've got this cervical plug and mucus and there's nothing that's going up the uterus, so it's a sterile environment. And then we learned that's the opposite of the truth. Whenever we check like PCR, we can see like tons of viral, bacterial. So just as people think of like, you know, healthy biome in the vagina, otherwise you're getting yeast infections, people are now starting to look at the uterus and endometrial environment microbiome. It's relatively new, which means the data is lacking, but it's an exciting part, and there are now tests to at least give you some objective measures. So I'm hoping you took away from this lecture like, whoa, I didn't know that existed. But I'm not endorsing anything, and if you're excited about anything, just talk to your doctor about it. Keep going, or is there questions?
There are some more questions, but I feel like, why don't you finish and then we'll continue to collect them and then we'll address everything after.
Okay, so inside the lab, a lot of exciting stuff. So I'm not an embryologist, I'm a physician, but I do bother the embryologist on a daily basis. In terms of the eggs, one comment that I thought was just crazy, when I learned about fertility through my training, one thing I thought was just crazy is that like, you couldn't score an egg. Like when I look at your eggs, I can't give you a score. This is a 9 out of 10, looks amazing. You could do that for sperm, you could do that for embryo, but not eggs. And I just thought that's crazy, which is why I founded this company called Future Fertility. This is all my shameless plugging going on here. And I thought artificial intelligence, by looking at that egg, could do something a human can't do. So that's what we're working on now. We're pretty much ready to go and launch the product. we're working on patients who are freezing the eggs to give them a personalized report what their chance of success is. So using artificial intelligence on the eggs, for me, is definitely an exciting technology that we're working on. There's something called spindle view, or some people call it oocyte. So in the picture here on the top right, you see, we call this a dark microscopy. So it's like the opposite of the light microscopy. And you can see this little white spot here. I don't know if you can see it. Vidya, can you guys see my arrow when I move it?
Yes.
Okay, so this little thing here is called a spindle, and you can't see that in a light microscope, only in this dark microscope. And this spindle actually is like where the chromosomes are stuck. Okay, so when the egg fertilizes, it sort of has to separate perfectly. So this is like the most important part, or one of the most important part. What we don't want is to put a needle through that when we're putting ICSI. So we sometimes use the spindle view to help us rotate the egg, so we know exactly where to drill the sperm. And some of us believe that, like, depending on the rotation of the spindle view, it gives us a little bit of insight about egg quality. Again, not talking about validation here, just technologies that are available. Okay. When we talk about sperm, just so everybody probably already knows, traditional IVF means you take an egg and you put thousands of sperm around the egg and you sort of say, like, battle of the best, good luck, let's see tomorrow if anybody fertilized it. ICSI, which is intracytoplasmic sperm injection, means we're picking a good-looking sperm, and we pick it based on like what it looks like and how fast it's moving, and we cut the tail off so we can capture it and we drill it into the egg. So that's IVF versus ICSI. There is a new company called Nayot that helps us prepare the sperm so that the embryologist can pick among the prepared sperm. Essentially, it's like a gauntlet race for the sperm. With different like pathways and sizes and material, and the sperm that can go from one side to the end have proven themselves as like the best of the best, and we can select out of the best of the best.
Is it like a maze?
Yeah, it's kind of like a maze.
Like Sperm Olympics.
Sperm Olympics, yeah. We only choose among the golds. Yeah. There is a technology called IMSI, so instead of ICSI, IMSI, which is, I think, intracytoplasmic morphology selective insemination. Essentially, it's like a microscope that's 20 times more magnified, so you can see what we look like I mean, these aren't great pictures in general, but this is how a sperm looks like in ICSI, and in IMSI, it's just a more magnified. The rationale there is if you can see better, maybe you can see more sperm defects better, maybe you can select better, maybe you'll have better outcomes. This requires a really expensive microscope. Very few labs have it. Most of them feel like the evidence doesn't support it, and whatever. But just so you know, that's out there. Okay. Let me move this along here. Okay, so embryo. So some of this is not new. So nowadays, traditionally, when we had eggs and we put sperm together, we would put them in the incubator, which is like a dark black box that's really controlled in terms of like temperature, pH, whatnot. And once a day, we would take it out to see how it's progressing. Somebody said, I've got a better idea than that. Let's put like an iPhone in there and take a video of the whole thing. And then we never have to take it out, which is genius. So those are called time-lapse incubator. There's several companies like the Embryoscope and Jerry, but essentially you get to see the entire development. Obviously it's not going to be a 5-day footage because that's going to take forever to review, but they hyper speed it up so that within a few minutes you get to see the whole development. This is a clever little app. So some of these time-lapse have these like real-time apps to them. So think of like that channel you watch at home with the fireplace or the fishbowl. So this is your embryo. So you get to see live your embryo development. I don't think they have it in North America. It's mostly in Europe. I'm hoping that everybody's noticing a trend about Europe and North America. And patients get to see it live. The feedback I've heard is like patients love it. And the feedback I've heard is embryologists hate it. Because they get phone calls at 2 a.m. saying like, my embryo's not moving. Did something happen? Can somebody do something? Or, you just can imagine sometimes the more you know, the more question it raises. But I think it's a cool technology. At least it lets you be part of the process. I think most people know about PGS, or now we call it PGTA. That's when we take a biopsy of the embryo and check for the chromosomes. So I don't think I have to talk about that too much. In the world of artificial intelligence, like I said, I'm working on the eggs because that's never been done, and I think it solves a big problem. There are several companies working on the embryos, and their thought process is, yeah, the embryologists are awesome at what they do, but maybe if we added artificial intelligence and they can pick the embryo better, then I'll get pregnant faster and my miscarriage will be lower. Again, these don't change the embryos, but it helps with the selection process.
So are labs including AI in their embryo selection then?
It's definitely the wave of the future. Some time-lapse incubators already have an AI algorithm, so they sort of say to you, hey, go for embryo number 6 based on 1,000 different things. I mean, I'm in this space, so I could tell you for sure in 5 years, but now it's like the early adopters who are into it. But I think there'll be demand from patients and embryologists and clinicians as time goes on. Okay. Other technologies out there. So there's something called the Gidget. Oh no, okay. So the Gidget, as you see here, is just a tracking tool. Again, that doesn't help with your outcomes, but it really helps with transparency. So every process, anytime someone touches your embryo or moves it, is tracked. I think it's an amazing, it's like obvious and amazing, but you can, like, for every embryo, you know where it was when. And that's just great for quality control and making sure, you know, a lot of times, let's say your eggs didn't turn to embryos, everyone's always wondering, like, did somebody leave them out in the sun? How do you know? You know, so it's a great transparency tool. We use a Trio, and I think it's great, even though I wasn't supposed to endorse anything. There is an awesome company called Overture. Overture is run by a brilliant guy named Santiago Munet, who was part of the PGS revolution. And his big vision that they're working on now is to sort of say, you know, labs are these big complicated things, but we can make it all, I can do a whole IVF in a single lab, in a single box. And in this box, we'll make sure every egg and embryo is managed, you know, optimally with 1,000 different variables. It's not yet ready for prime time, but that's what they're working on behind the scenes. There's a company called Tomorrow, Clever, no vowels, TMRW. And what they said is, like, if anyone's ever seen what the tanks look like in the IVF lab, they're just huge canisters with alarms, with liquid nitrogen, but they're not very, you know, techy. So they just said, like, why don't we make the incubator of the future, and sort of did it like a vending machine. So, you know, you press the code of the patient and it goes in and makes sure it's got the right embryo, and, you know, it's connected to patient's phone. So anytime anyone's touched your embryo, you know, or you can get live updates on, like, the temperature. You know, the whole field is moving towards automation and transparency. There is a company called InvoCell. This one's probably been around 5 to 10 years. I think it goes in highs and lows of, like, excitement and usage. I think there was a clinic called, forgot their name. The whole point of InvoCell is the following. They said, like, listen, the lab is really expensive. IVF is really expensive. And we think we can use your vagina as the incubator. It has, like, the right light and the right pH and the right, so essentially you go through IVF where you take out the eggs, you fertilize them inside the lab, but then you put it into this little culture device. And you put this culture device almost like a cervical cap, and women hold that in their vagina, kind of like a diaphragm, for 5 days. And 5 days later, you take it out, and the embryologist checks, and he hopefully says there's at least one good-looking embryo, and he puts in that embryo, and he'll freeze the rest. So you're sort of those 5 days. I can't comment. I don't know. I guess sort of the angle here is it's cheaper. There are probably some patients who feel more connected to the whole process by doing that. But yeah, I mean, it's just a technology that's out there. I'm going to keep rambling unless you want to.
I can ask you a couple of questions now if you want.
No, yeah, I think that's sort of the end of my shallow highlighting of what's cool and new out there.
That's really, like, honestly, everything sounds really cool and new. I almost want to do it all again, except that I don't. Okay, can we talk about any advances in frozen embryo transfers? Are you seeing anything new, any new techniques, new technology?
So frozen embryo. So one huge advancement, which isn't new, is the way we freeze them. So now it's called rapid vitrification, which is pretty standard these days. So one thing people take for granted is that, like, when we thaw the embryos, they're there, they survived. People just assume it's going to happen. It's probably over 95% across the IVF clinics. So we've done a really good job, but that's a relatively breakthrough thing. But once you have a thawed embryo, how do we increase success rates? Again, if your embryo is abnormal, there's nothing downstream from that you can do to reverse that. The real question is, if you have a normal embryo, how do you optimize the chance that it's going to work? I think that's like a 2-hour lecture. But those are things like, again, I'm not endorsing anything, but technology, so we sort of spoke about, are things like, hey, the matrix to sort of give us an idea if you're receptive, or endometrial biopsies, or a tociband, or, embryo glue. There's lots of, I'm not saying anything about the evidence of them, but there's lots of things that people have tried.
There was another question about embryo glue. Can you talk a little bit about that? I've never heard that term before.
Yeah, so embryo glue is like another brilliant name. So embryo glue is, so when we put when we do the transfer, we gently put the embryo into the uterus and hope that it implants. There is a medication called embryo glue. So it's kind of like, so when we put it in, we have to put it with some sort of culture media so it doesn't stick to the catheter. So embryo glue is a type of culture media. It has a special ingredient called hydroloneric acid. And the thought process is it's going to improve the implantation. So you should be using embryo glue with your embryo transfer. Again, I'm not going to go into the evidence of whether it works or not, but there's, I like two things. I like the clever names always, and I like the rationale to say, hey, maybe this is the bottleneck, and let's try to find something to fix that bottleneck. Kind of like oxytocin is thinking, hey, maybe it's the cramping that's dislodging nice embryos. Let's try. I'm just talking here about rationales.
Right.
Yeah.
You talked a bit about advances in sperm sorting for high DNA fragmentation. I think we talked about like the Sperm Olympics, and what is there any other kind of sorting mechanisms to treat for male factor?
So you have to appreciate that regardless of how we sort, the final decision is a human picking a sperm. So if there is no good sperm, doesn't matter what they pick. But most of us who, the trained embryologists try to pick the best sperm, hoping that represents a high quality sperm.
Okay.
Yeah.
Can we talk about diagnostic testing a bit?
Okay.
I know that a challenge for many couples is the unexplained infertility diagnosis. Is there anything new in terms of figuring out someone's diagnosis without resulting in an unexplained?
Yeah. Okay. Bear with me for another 10 minutes answer. Okay. So first of all, the term unexplained means the doctor doesn't know why you're not getting pregnant. Traditionally, we use that term if we check a few big things and they're okay. So does she ovulate? Are her tubes open? Do we think her uterus is normal? And is the sperm fine? If so, it's unexplained. Okay. The way I sort of talk to my patients about fertility is the following. When we're looking for a reason, sometimes there's a black and white reason. We say that's for sure the reason. And most of the time, everything is great. In gray, we have to figure out if it's like relevant or incidental. So for example, just because your thyroid's a little bit low doesn't mean that's the cause of your infertility. I'm not saying it isn't, maybe it's contributing, but you don't really know that that's the cause, right? Black and white things are like, you're in menopause, well, then you're not releasing eggs. That's probably why you're not getting pregnant. Your tubes are blocked. You were born without a uterus. You can't have intercourse for several reasons. There is no sperm. Those are black and white things. The rest of them is great things. So to me, I think unexplained is complicated because a lot of physicians and patients, as long as you find one great thing, we hang all our hat on that and we say, well, that's the only thing we can find. It's therefore the thing. So, if somebody's unexplained but they're overweight, we say, well, it's probably related to your weight and egg quality. I mean, maybe that's true, maybe it's not. If your thyroid's a bit off, we say, well, it certainly could be from your thyroid. I'm not saying it's not the right approach. I'm just saying, even with diagnostics, there isn't going to be a diagnosis that says like, there's the reason. But the way I think you need to look at it is you need to look for like patterns and use logic. So for example, let's say you've never been pregnant before and you go through IVF and you keep making these beautiful embryos and tested normal and they look fantastic and it's not implanting. Probably your issue is not the seed, it's not the egg and the sperm and the embryo, it's probably something to do with implantation, right? So you have to take the whole story and look for patterns. But mostly this unexplained, a lot of times we figure it out as we go along. So a lot of trial and error, unfortunately.
Dan, we're almost rounding out an hour.
Yeah.
I'm going to give it to you. Do you have time to keep going or do you want to
I'm fine.
Holiday? Sorry?
No, I'm okay to go.
Okay, let's ask a couple more then. Is there a reason why using human-derived cells versus animal-synthesized hormones is more successful?
That's a very specific question. So I didn't say that it was more successful, so Recovil is a human-derived recombinant FSH, and something like Puregon or gonalf is a animal-derived. I think that's a whole lecture, but in general, it depends how it's debatable whether one is more effective than the other.
Okay. I guess it depends on the person and how they take it.
Indication and things like that.
Okay. There's one about the Ontario funded program. Do you know enough about the funding program to answer a question about frozen transfers and fresh transfers?
I can try, but I'm certainly not the authority. But there is a really awesome website that Trio put on. I think it's called like Ontario Fertility Review or something like that. It's like a free website that sort of talks about like what's included and what's not.
Okay, and we also did a Facebook Live on Wednesday about the Ontario funded program. So maybe check that out and your answers there.
I can try, but you can shoot it.
Okay, Ontario funded program pays for FETs unless something, oh, sorry, that's a response to a question. I'm sorry. Okay, because the Ontario funded program requires a fresh transfer and frozen seem to be more successful, is the Ontario program out of date scientifically?
That's news to me. I don't think the Ontario program mandates a fresh transfer.
Okay.
If it is, it's the first I've heard, and I'm in trouble.
My understanding might be a little outdated as well, but I didn't have to go through a fresh transfer when I did mine.
I think the Ontario, one thing they do really well is they sort of say like that's between the doctor and the patient. We'll fund one cycle, but whatever you think is appropriate, then that's what they don't tell us which drugs to use or how much drugs or fresh or frozen. The only thing they sort of limit is like the age when you can try it. So you've got to be under 43 and the number of embryos, because again, the big goal here is one baby at a time.
Right. Embryo glue, maybe it's the name of it, seems to be a popular topic here. Does embryo glue really help? Doesn't the embryo have to roll around to find its own best spot?
Yeah. So you're asking my personal opinion. My personal opinion, when I've reviewed the literature, I don't believe it improves success rates. But I can appreciate that others feel differently.
Okay. I think we've gotten all of the questions. I'd like to leave it to you. Is there anything else that you think we need to know?
I don't know. I would say, like, not everything new means better, and not everything, like, I think you have to apply it accordingly. A lot of times it's like a cost benefit analysis. I just think it's good to empower people of what's out there to at least have that discussion.
I totally agree. I think that, like, you know, a lot of fertility treatments have been paused right now, and a lot of people are out there feeling a little hopeless right now, but maybe knowing that there are constant advances in the field is giving you something to look forward to when things return to a bit more normal.
Totally. I mean, if you want to talk about like where we were 30 years ago, the pregnancy rates were like 5%. Now they're as high as like 30, 40%. They used to literally do laparotomies, like C-section type surgeries to try to get those eggs, which sounds crazy to anyone going through
Wow.
IVF, but that's what they used to do. And they used to do it, they had less control of, we didn't have all the drugs we have now, so they would do it at like 4 a.m. to try to get 2 eggs and things like that. So like we've come a long way, and like in our lifetime, things are going to be super different.
I agree. I hope that you'll come back maybe a couple of months from now and give us a whole new presentation with all of the brand new stuff that's going on.
Cool. Yeah, I'd love to.
Okay. Thanks so much, Dr. Nayot.
Okay. Take care.
For everyone who was able to join us today, thank you so much for joining us. As I mentioned earlier, Fertility Matters is a not-for-profit organization, and if you're in a position right now where you can donate anything, every little penny counts. So please pop onto the Facebook page and click the donate button if you can. And I just wish everyone out there good luck in your journeys, and wishing you all the best.
Yeah.